My job this morning is to provide a bit of background and history related to this conference, and specifically to describe the evolution of the life participation approach to aphasia and Aphasia Access. For many of you, I know this is going to be a review, but I think it's important to set a context for the next couple of days and make sure we're all starting from the same base. So, first, I'll give you a little history. Then I'll talk about Living with Aphasia Framework for Outcome Measurement to help us situate our thinking about LPAA. And finally, I'll talk in more depth about the key values and concepts of the life participation approach to aphasia. So, to start with, I'd like to create a bit of context with a story about a patient that I had back in the 1980s. Sarah was a 61-year-old lady who managed an attorney's office. She had loads of friends, multiple interests. She was what I would really describe as a go-getter. Shortly after a big anniversary party that she had organized, Sarah had a stroke, resulting in significant non-fluent aphasia and right hemiparesis. She participated in inpatient and outpatient rehab and was then discharged to live at home with her husband. Her outpatient discharge report stated that her language recovery had stabilized, and she was described at that point as having moderate Broca's aphasia. Her communication was described as functional for managing at home. Her SLP described her as enthusiastic and motivated and anxious to get home to resume her life, a story that a lot of us have probably heard. I became involved with Sarah about a year after onset when I received a call from Sarah's husband, who felt that she really needed to come back into therapy. He described her as depressed and said she had pretty much stopped communicating. When I first saw her, her communication was actually consistent with what the discharge report said, moderate Broca's aphasia. She was pretty good at getting her point across, and socially she was delightful. She was really a lovely lady. I noted from her discharge report that she had worked on things like lexical retrieval, sentence formulation, writing, and some functional communication tasks. And all of that seemed perfectly appropriate to her impairment. However, it was clear from sitting with Sarah that she was bored, depressed, and very, very insecure. She said she couldn't talk, and so she really couldn't maintain her friendships. Her friends had really drifted away. Her prior activities, like managing an annual charity ball, playing bridge, and working at her job, she said were no longer appropriate for her. She said she had no reason to get up in the morning other than cleaning the house and doing laundry and that sort of thing, pretty grim. She didn't seem to have the skills or the confidence to re-engage in her former life activities or find new outlets for her life. Her focus was on what she could not do rather than on her strengths and potential. Her husband, an engineer, didn't understand aphasia. He didn't understand his role in her recovery, and he was impatient with Sarah's change in personality from a vibrant and outgoing woman to a withdrawn and anxious wreck. So what had happened in the 6 months after her discharge from aphasia therapy? Sarah was a perfect example of someone who significantly improved in language but remained socially isolated and depressed. In short, Sarah was not living well with aphasia. In fact, Sarah's situation is at the core of the life participation approach to aphasia. That is, addressing the need for language recovery, but also figuring out how to support life with residual aphasia. So this story is one reason that many of us became involved in LPAA and similar philosophies, the need for a broader conception of aphasia rehab. But recognition of this dilemma didn't start in the 1980s when I saw Sarah. The path to LPAA goes back much farther. Back in the 1950s, Martha Taylor Sarno was advocating for attention to how the person with aphasia lives life. She implored clinicians to consider functional aspects of communication. She also worried about psychosocial consequences. In fact, she wrote, "The literature reflects little research and sporadic, generally unsustained interest in the psychosocial sequela of aphasia. In clinical practice, this aspect of aphasia is often acknowledged, but not addressed or managed." So the journey towards a life participation model began years ago with Martha Taylor Sarno leading the way. And of course, others were front and center on this path. Audrey Holland talked about the fact that people with aphasia can, in fact, communicate, even if they can't talk. She stressed that there's more to communication than language and incorporated the growing literature on pragmatics into aphasiology. In her usual cut-to-the-chase manner, Audrey said in 1983, "Clinicians might try talking to patients occasionally instead of only working on their language problems." It's interesting how this comment way back in the 80s foreshadowed her contributions in the area of life coaching and counseling. The problem at the time that Martha and Audrey were urging clinicians to pay attention to the whole person was the prevailing healthcare model, the medical model. In this model, the healthcare provider is the expert who directs treatment in a relatively authoritarian manner, creating a power asymmetry in the relationship. In the medical model, the person with aphasia is the problem, so the aim is to fix the person. In the medical model, the explicit goal is recovery of language to restore language to normal or premorbid abilities. If language is not recovering, then the patient's discharged, that idea of the treatment plateau. Theoretically driven treatments that were emerging, such as psychotherapy and psycholinguistic approaches, fit well into the prevailing medical model, where the need to recover from impairments was paramount. And clinicians were swept along in the desire to be part of the established medical community. But there were niggling worries about clients like aphasia, who we thought back in our minds should be better. They should be doing better than they were. As we entered the 1990s, aphasia services began to experience pressures from various directions. Diminished healthcare dollars meant that we could no longer offer long-term treatment for aphasia. Discharges came sooner and sooner after onset. Also, at the front end, swallowing began to take precedence, resulting in fewer sessions devoted to aphasia. Other professionals began to take an interest in treating aphasia. The combined result was a decidedly negative impact on our aphasia services. So clinicians were forced to make decisions about what to treat in an increasingly narrow clinical window. Around this time, a group of like-minded clinicians and researchers began to talk about the state of aphasia services and brainstorm ways to address the issues. And these are just a few of these early thinkers that were communicating about these problems. We began to ask questions like, how can we deliver services that make a difference even within the current healthcare climate? What do we need to change so that people with aphasia can participate more successfully in their lives? This led to a small conference in the Napa Valley in 1997. So with a little wine and a lot of creativity, or maybe it was a lot of wine and a little creativity, I'm not quite sure, we began to address the concerns. While we were espousing various approaches and ideas, there were commonalities that seemed to tie things together. And the commonalities really fit within a social model of aphasia. Now, a social model is a term that's actually a broad, generic umbrella term. It's been used extensively for many years in sociology and anthropology to refer to models that help explain how a social group or a system is organized. The purpose of social models is to understand something from a social or cultural perspective. So if we understand how the social system is organized, we can deal with a problem and try and improve things by focusing on the person and also on the system around the person. And so that got us really focusing not only on the person with aphasia, but on the environment and the system as well. Social model does not refer to socializing as an activity, like chatting at a cocktail party or sitting at lunch and talking to your friends. It's a broad philosophical orientation. In fact, if you Google social model, you'll find a plethora of hits with social models of everything from cult formation to social models of childbirth. So a social model really suggested a need to understand what aphasia means to the person within his or her own community and to the community around the person. It meant expanding our definition of communication from information transfer to social action. So not just about transmitting messages, but about managing social interactions and managing your membership in society. The model focuses on the broad life context of the person. And in the social model, we appreciate communication in relation to things like social dynamics, identity, power, and societal norms and expectations. Aspects of the social model also drew from the narrower socio-political disability movement, and more specifically, social models of disability that assume that barriers and exclusion from society are key factors in actually creating disability. The idea is to change society and change the environment to reduce those barriers. This effectively moved the locus of the problem outside of the person with aphasia. By adopting the social model, we move towards person-centered care and away from the expert or clinician-centered paradigm within the medical model. So people with aphasia are seen as the experts on life with aphasia. The focus is on the therapy relationship as a true partnership. And increased accountability of service providers to clients is recognized. So we begin to see the importance of people with aphasia serving on research review boards and ethics panels, of being part of their own future. Because of the strong philosophical contrast with the prevailing medical model, and yes, this is a little bit of a biased picture here, with the medical model all prickly and gray. But with the marked contrast, the social model thinking helped clinicians and researchers grasp that a new paradigm was needed to drive aphasia management. In 1999, another conference was held, resulting in formation of a group to formulate a set of principles or values, the values that we now know as the life participation approach to aphasia. LPAA is an example of principles based on a social model of aphasia. The principles were designed to guide assessment, intervention, and research. And the idea was to not be prescriptive regarding actual domains of intervention, but rather have some very clear guidelines or values that would help orient people. We chose the term life participation because participation in life situations of one's own choosing, is at the core of well-being. And research tells us that people with aphasia and families have reported that doing things is a key factor in living successfully with aphasia. In fact, researchers have suggested that participation level outcomes are probably the strongest correlate of quality of life, above and beyond activities or impairments. So we worked on a statement of values until concluding with the document that was ultimately published in the ASHA Leader in 2000, at the turn of the century. That sounds so funny. When LPA was introduced, its appeal to clinicians was immediately clear. It seemed to address a need that clinicians intuitively recognized, and people joined the paradigm shift. Older ideas were recast, and creative new ideas emerged to fit under that broad LPA umbrella. It was a period of creativity and excitement. On a broader scale, changes occurred in the area of service delivery. For example, participation-oriented aphasia programs or aphasia centers began to pop up. A survey that Audrey and I conducted in 2010 showed that the number of programs grew from 7 in 2000 to a total of 26 in 2010. And of course, many more have opened since then. These programs offered groups where people with aphasia could not only improve conversation and language, but also make friends and negotiate a new identity. These centers incorporated activities that supported participation, such as computer groups, art, exercise classes, theater groups, and on and on. The speech pathologists involved in these programs reported remarkable changes in their members. Not only improved language, but also changes in confidence and self-esteem, enhanced engagement outside of center programs. But with success in making a paradigm shift, new challenges arose. Traditional funders, such as insurance companies, were not familiar with non-traditional services. People who were trained as clinicians were faced with learning how to market their programs or how to administer a program. Many questions arose, such as how do I incorporate LPAA into traditional health care? How do I get money for doing what I'm doing? What assessment tools are appropriate, and on and on. To find out the answers, clinicians and researchers around North America began trying to connect to deal with the issues involved in applying a new paradigm. In 2011, Elaine and Mike Adler, with their usual vision and commitment, hosted a group at the Adler Aphasia Center in New Jersey to talk about how to support one another, how to share information, and how to move forward. The outcome of the meeting was a loose alliance with the goal of giving each other support and information. 2 years later, in 2013, a second meeting was held in Midland, Texas, hosted by the Aphasia Center of West Texas. At this meeting, it was agreed that our loose organization should become more formalized and opened up to more people. We recognized that there were organizations with missions to serve people with aphasia and their families, such as the National Aphasia Association, and groups designed to foster research, such as the Clinical Aphasiology Conference or Academy of Aphasia. But we identified a gap. There was a need for an organization for professionals or service providers, a resource for LPAA, something that facilitated peer-to-peer networking, ongoing education, not only how to start an LPAA program, but also how to promote and sustain it. We wanted to collectively bring everyone together to make an impact on practice and on healthcare in general. Our deliberations resulted in the formation of Aphasia Access, a 501c3 nonprofit organization aimed at providing information and support to professionals and providers serving people with aphasia, and also growing leadership aimed at improving communication access and life participation. So Aphasia Access was formed to bring together providers, researchers, academics, and community leaders with the end goal of making a better world for people with aphasia. So there you have a history of sorts. Now I want to circle back and go into more detail about a supporting framework and guiding principles for LPAA. First, let's look at framing LPAA. You're all probably familiar with the World Health Organization International Classification of Functioning, Disability, and Health, or ICF. An adaptation of the ICF framework, with which you also might be familiar, is Living with Aphasia, Framework for Outcome Measurement, or AFROM. AFROM basically adapts the ICF to specifically address life with aphasia. It draws from the perspectives of people with aphasia and their families based on a series of focus groups that were conducted at the Aphasia Institute. The framework is designed to be broad and non-prescriptive. That is, it doesn't dictate what you do in treatment or assessment, but rather helps organize thinking about those endeavors. Here you see the AFROM graphic depicting 4 overall snapshot domains and a dynamic intersection of these key domains, creating life with aphasia at the center, which of course is a concept similar to quality of life, but focused specifically on living with aphasia. At the bottom, language and related impairments refers to the actual aphasic processing impairment. The language snapshot domain encompasses categories related to the underlying processing, mental processing required for speaking, understanding, reading, and writing. So this domain is where we focus treatment when we're working on something like confrontation naming or a didactic task like following one-step directions, with the goal of improving linguistic processing. All of the domains in AFROM can be broken down into increasingly narrow elements. So, for example, here's just an example of how we might break down the language domain if we're working on something like writing single letters. But the idea of AFROM is to always bridge back to the snapshot domain and the ultimate target, which is participating in life with aphasia. So the idea is to always be clear and explicit how we're moving back up towards that big picture outcome, life with aphasia. Participation refers to the roles, life situations, and activities that are unique to the individual. This includes categories such as conversation, roles and responsibilities, relationships, relevant activities. Personal factors are internal characteristics of the individual, such as age, gender, culture, ethnicity, or psychosocial factors such as personality, confidence, optimism, or identity. Finally, we have environmental factors. Those are the factors external to the person that can either facilitate communication or get in the way. Things like the skill of speaking partners, attitudes of other people, physical characteristics of the environment, or systems, services, policies. So these 4 snapshot domains interact in a dynamic and overlapping way to create life with aphasia at the center. So the idea is to use AFROM as a map, a simple common framework to help us focus on the end goal at the center to improve the person's life. It encourages multidirectional thinking and highlights that the domains all interact so they don't stand alone. So AFROM serves as the background for understanding LPAA. So let's shift gears a bit and move into the foreground to talk in more detail about the values of LPAA. The first value states that the explicit goal is enhancement of life participation. In other words, individual life participation goals are the outcomes of overriding importance. The way one achieves this is not prescribed. The domain or domains of intervention are those that will most effectively and efficiently achieve positive participation outcomes. So this focus on participation often is a misunderstanding of LPAA. LPAA does not mean that we work only on participation. If working on the environment is the best way to achieve a meaningful outcome, then we should work on the environment. If working on the language impairment is the best way to achieve the outcome, then we work on the language impairment. So it's not, LPAA is not anti-impairment therapy. It definitely isn't. Work on impairment is part of the package. It's just not the only part of the package. And of course, there are many approaches or combination of approaches that might achieve a participation goal. It doesn't mean that all has to be done by the SLP. I think Maura Silverman's going to talk about one of the things that she does, recruiting people in the community to support the person with aphasia and extend the reach of the speech pathology outside of our own abilities. So there are lots of ways to achieve LPAA goals, but the key is that we can't just, the old saying, train in hope. We must make the outcome goals explicit and determine whether we're achieving those outcome goals, which of course brings us to the next value. Measures of success include documented life enhancement changes. This value is the assessment version of the first principle. Not only must the goals explicitly address meaningful life changes, but assessment should measure those targeted outcomes. And that's why patient-reported outcomes become a real priority, because we have to know whether or not they're feeling like they're participating more in their lives. The third principle states that all those affected by aphasia are entitled to service. We know that aphasia affects more than just the person with aphasia. If those around the person are not sufficiently knowledgeable, if they're not supported, then outcomes of the person with aphasia may be less desirable. And of course, research has demonstrated that supportive relationships are associated with better success in living with aphasia. The fourth value states that both personal and environmental factors are targets of intervention. And so, as I already said, LPAA extends intervention into all domains of AFROM. Since personal or psychosocial factors, such as mood or confidence, are considered sometimes potential casualties of aphasia, intervention includes mechanisms for addressing these, like counseling or identity work or self-advocacy groups. And LPAA also requires that we attend to the communication environment to remove barriers and implement adaptations and supports. And this means not only the immediate environment, such as regular communication partners or having support materials available to the person, but also the extended environment, the community and society at large. So intervention may include changing larger systems. And this, of course, goes beyond the typical day-to-day clinical work and extends our work into the realm of advocacy, public relations, and leadership. The emphasis is on availability of services as needed at all stages of aphasia. So LPA begins at the onset of aphasia. The philosophy spans life with aphasia. Even immediately after onset, participation goals should drive intervention. A person with aphasia in an acute hospital needs to be able to understand and talk about what happened. They need to be able to communicate with their family. They need to understand safety precautions. These things are immediate communication needs. They can't wait for linguistic recovery. From an LPAA perspective, we need to help the person negotiate these communication needs in the here and now, either by working directly with the patient or working on the environment and the communication partners around the patient. This doesn't mean that we can't work on linguistic processing to facilitate recovery of language, only that we keep present as well as future communication needs as the primary target, and make decisions based on the best way of getting to those targets. And also, LPAA extends across the lifespan. So someone with aphasia might want to re-enter treatment, like Sarah, or Sarah's husband, actually, and achieve a new goal to help with a new issue. This is perhaps the value that in our traditional healthcare system is often the most difficult to achieve, but it can be achieved by looking at a continuum of services that go beyond traditional healthcare. So things like university clinics, community programs, aphasia centers, self-help groups, and things like that. So let's look back at Sarah. In Sarah's case, intervention focused primarily here on treatment of the language impairment, and she got better. She also had a little bit of attention to what I call functional splinter tasks, and you're going to hear a little bit of one of my pet peeves here. So Sarah worked on something like writing checks, but this is only a splinter of the larger life role. Sarah didn't achieve the larger life role of managing her finances or doing multiple aspects of that big picture task. And in fact, she said she felt ridiculous, just writing checks when she wasn't really able to navigate the checkbook. She couldn't call people up and say, why is this bill wrong? And so her husband continued to manage all of the family finances, even though she had gotten to where she could write checks. So that splinter task really didn't help Sarah navigate a life situation. No effort was made to look at the big picture of how Sarah's skills fit into her life, to look at what she would be doing to feel fulfilled and engaged after discharge, to look at what communication skills and personal attributes she could employ to try new things. LPAA would provide us with guidance about how Sarah's rehab might have followed a different course. Attention should have been given to life after discharge. What would it look like? Would it fit Sarah's outgoing and vital personality? What would she do to fill her need to feel active and engaged? How would her communication skills serve those needs? The idea of beginning with the end in mind, looking down the road to see where we're headed, is critical. We can't allow the goal of aphasia therapy to be improved scores on the Western Aphasia Battery. We have to attend to the skills, personal attributes, and supports required to meet life goals. So I want to end with some threads that I think weave the fabric of LPAA. That's a little metaphorically over the top, I guess, but actually, key takeaways is probably a more straightforward way to say it. And this is going to repeat some of what I've already said in the values, but I think repetition's important. Isn't that one of the principles of neuroplasticity? So the ultimate goal of aphasia rehab is communication participation. And improved language is insignificant if it's not used in the service of a life well lived. To know what will contribute to a life well lived, we need to ask people affected by aphasia. There was an interesting study by Linda Worrell and her colleagues where they asked people with aphasia, their family members, and speech-language pathologists what their goals were for aphasia rehab. And people with aphasia and their families said goals that all fit within the ICF category of activities and participation largely, whereas SLP goals largely fit in the category of language impairments. So how do we reconcile that kind of mismatch? Neither's wrong, really, but LPAA would suggest that we have to incorporate the goals for participation that are defined by people with aphasia and their families. And then SLPs use their expertise to identify the interventions that are likely to effectively and efficiently achieve those goals. So, you know, instead of us giving the Western Aphasia Battery and identifying some goals, it's really up to us to go to the patient and family and work with them to identify goals and then use our knowledge and training to figure out how you get there. This is a lot more messy than simply giving the WAB or the BDAE and working on improving, you know, semantic processing. I'll never forget, I was working with a lady some years back, and I was talking to her about her goals for the next 6 weeks or next 6 months, and what she said, her goal was to divorce her husband. And I thought, ooh, that's going to look good in the chart. What to do? Well, that really, with this lady, what we ended up doing was working on her independence in managing her own affairs. We developed a network of support people, friends as well as professionals. So the goal was not actually divorce, but addressing the issues that prevented her from making that choice. Her feelings of autonomy, the ability to negotiate her world without her husband doing it for her. Another thread is that communication participation takes more than language proficiency. Think about something as pervasive as conversation. You have conversations all the time. Certainly, you need language processing, words, grammar, and so forth. But you also need an opportunity to have a conversation, someone to talk to, and maybe a place where you can talk that isn't noisy or distracting or uncomfortable. Conversation works best when the other person is a good partner. If they don't listen to you or if they treat you like you have no sense, then it's not going to be very successful. You need to feel confident that you won't make a fool of yourself, or at least not totally. So language processing is never the only factor that influences how we participate in communication events. These other domains are immensely important. Martha Taylor Sarno sums it up rather eloquently. She says, "It seems evident that a condition that strikes at the very heart of personhood, our ability to communicate, calls for an intervention model that accounts for everything we know about humans." Lovely, isn't it? Another thread is that aphasia is typically chronic. Some people do recover pre-onset function, but most people with a significant aphasia do not fully recover. They have residual language problems. If treatment focuses only on linguistic recovery, then clients and their loved ones are left to negotiate a life with residual language problems, and maybe without the tools or the resources or the knowledge to manage their life, their communication. So intervention should be designed in consideration of how residual aphasia will affect life over the long term. And how you live your life matters to your brain. Life participation is actually directly tied to brain health. The brain circuitry changes microscopically with experience and activity. You know this, it's the concept of neuroplasticity. When we use a function, the connections between brain cells strengthen and change. When we stop using a function, disuse results in weakening of connections and atrophy. So the principle of use it or lose it is important. When communication becomes difficult, you might communicate less, and the related circuits start to weaken from non-use. The flip side of this is use it and improve it. So we want to ensure the opportunities and skills needed for people to use their language in rich and rewarding ways. Successful participation in worthwhile activities is good for the brain. How we feel about ourselves and our communication directly impacts what we do from day to day. If we feel embarrassed and incompetent as communicators, I know I'm less likely to risk calling up a friend or going to a social event if I don't have confidence. I take a less active role in conversation when I don't feel confident. So we're back to this whole use it or lose it idea. Psychosocial factors contribute immensely to the whole idea of non-use. Remember Sarah? She had pretty much withdrawn from communicating. So we can't ignore the psychosocial and emotional side of communication. It's a significant factor. Therapy is not about tasks. The therapeutic relationship with the client is the locus of behavior change, not the tasks themselves. When the relationship demonstrates equality of power and respect, we are in effect working on negotiating a person's identity and self-worth, supporting personhood and self-competence. I think I made up that word, self-competence. Isn't it good? The relationship with the SLP and with others in those early stages can help start the person on a road towards feeling valued and capable. Who we communicate with matters. Think of your own experiences. When you have a conversation with someone who makes you feel good about yourself, isn't it great? A skilled partner brings not only skill in helping the person with aphasia get message across, but also brings skill in supporting the social relationship, in fostering self-worth. Roberta Ellman talks a lot about key components of aphasia therapy, and one of them is connecting the person with aphasia with other people. If those other people are knowledgeable about aphasia and skillful in supporting conversation, then this contributes immensely to communicative participation. So making sure that people with aphasia have skilled and knowledgeable people around them is part of the package. Context matters. This means that the context of therapy, as well as the context of the person's life, anywhere along the aphasia continuum. When we're functioning in a supportive environment, we tend to flourish. This doesn't mean that we shouldn't have challenges. Challenges keep our brains engaged. But characteristics of the environment can facilitate communication and participation or stifle it. Some interesting research by Bernhardt and colleagues found that in the first 14 days after onset, stroke patients were in or beside their beds over 88% of the time during the day, and they were alone for 60% of the time. So think about that context. Sounds a lot like forced non-use. Remember, use it or lose it? It certainly doesn't support communicative engagement for those people. In a similar study of hospital inpatients, Aaron Gadecki and colleagues found that people with aphasia spent more time alone than people without aphasia who had had strokes. So this non-use issue is even more apparent for people with aphasia. And my guess is that this would be similar in many long-term care facilities and maybe even in some people's homes where people with aphasia spend more time alone and without rich communication opportunities. And maybe y'all have some ideas about that too. The final thread is that truly changing outcomes for people affected by aphasia requires clinicians to implement LPAA values and practices, but it also requires changes in the broader systems in which we operate. So, for example, changes in communication access in healthcare environments and communities. We need a continuum of care so that clients can move through the healthcare system and each segment, acute care, inpatient rehab, outpatient, community, and so forth, are all working towards a life well lived, not simply a series of fragmented short-term goals. Systems must not only offer services immediately after onset, but support services during chronic stages of aphasia. As I think about these LPAA threads, I'm really excited and optimistic about where we're headed. We have a wonderful opportunity to come together through Aphasia Access to meet challenges and address opportunities. So let's look at some of these potential opportunities, and maybe y'all have many more. We might work as a group to advance communication access in healthcare and communities, to educate healthcare administrators and policymakers, to explore and promote better funding mechanisms, to facilitate support networks for clinicians and programs. I think Aphasia Access can be a driving force in exploring and circulating innovative program ideas, providing guidance about marketing, business, and fundraising, developing research priorities and evidence, integrating LPAA concepts into academic programs and clinical training. And of course, by creating this network, we can work towards improvements in how we actually conceptualize life participation approaches to aphasia, so that idea of continuous quality improvement. So Aphasia Access was formed to bring people together to find creative ways to move aphasia management forward. That's why we're here. And so, time to get going. Thank you.